Professor Sanaء عبد الرحمن. Professor Sanaء عبد الرحمن, Professor of Pediatrics, Ain Shams University. She is well-known figure of neonatology, immunology, and allergy. Actually, Professor Sanaء was my teacher and mentor many years ago. Of course, Professor Sanaء Yusuf is my teacher. In addition, Professor Sanaء actually moved to the United States of America, and now she is Professor of Pediatrics, Allergy, Immunology, Pikeville University, Kentucky, Adjunct Faculty, Lincoln Memorial University in Tennessee, United States. I have the pleasure and honor again to present you Professor Sanaء, and we'll starting your lecture today is about asthma, hot topics, pediatric asthma, hot topics. Professor Sanaء.
The appreciation to my colleagues who invited me to attend this meeting. To attend this meeting. I will say ladies first, Dr. Iman Fouda, Dr. May Nassar, Dr. Sarwa Duraz, and Dr. Ihab Khairi for their very kind invitation. And I would love also to extend my sincere thanks and gratitude to the whole pediatric department headed by Dr. Mona Ganzouri and the rest of the reputable colleagues. In the beginning as well, I want to extend my sincere condolences to you guys and myself for the loss of our eminent professor, Dr. Yahya Gamal, and all our professors who had left us to the highest ranks of paradise, inshallah. I would, in this presentation, will focus on some of the hot topics in the pediatric asthma that probably you've missed reading in the last year. As for the disclosures, I have nothing to disclose. Those topics will be involving the T2 high versus the T2 low asthma articles, the COVID-19 and pediatric asthma, vitamin D, rhinoviruses, and I will end up with the medical changes according to the American Academy of Pediatrics. As you all know, since 1947, asthma was classified as extrinsic asthma and intrinsic asthma. And extrinsic asthma, the one that involves allergic sensitization as well as childhood asthma. And the intrinsic asthma is, as you all know, the older age onset asthma with less sensitization and with decreased lung function. But this has changed in the relatively recent years, not that recent, with the word TH2. TH2 asthma pathogenesis, a little bit of discussion. You remember the lymphocytes, the TH2 is the one responsible for allergies. And with its cytokines, the IL-4, IL-5, and IL-13. To block the lymphocytes, generally speaking, we used to use glucocorticoids in the past and as well as nowadays. But the recent thing of the targeted therapy or precision therapy is targeting towards cytokines that will involve the proper remodeling and the hyperreactivity. What about the current classification? The current classification of asthma, as you all know, is the endotypes as well as the phenotypes. And we used to say the endotypes, the allergic type, the Th2 and non-Th2, which entails the different pathogenic mechanisms, cellular and molecular. Recently, we don't use Th2. We use the word T2, T2 high or non-T2, or the other word T2 low. The phenotypes means the variable clinical presentation that involves the atopic asthma, the non-atopic asthma, asthma in the smokers or elderly, or aspirin exacerbated respiratory disorders. Again, in the recent years, a little bit of immunology, it's not that much. What is the innate lymphoid cells? We used to say the innate immune system involves the dendritic cells, the macrophages, the natural killer cells, but those innate lymphoid cells, type 1, type 2, and type 3, are really important. What is important to us today in the talk of the asthma is interleukin innate lymphoid cell 2, because it secretes a lot of cytokines similar to the Th2 cell. And actually, it secretes more IL-4, IL-5, and IL-13. So that's why we say type 2, not Th2. Why? Because of the contribution of the innate lymphoid cells, type 2, in addition to the Th2. When the epithelium is affected by the allergens or air pollution or viruses, alarmins are secreted. That involves other cytokines. I'm not going to talk about it, but I will tell you, recently, there are a lot of cytokines working on the epithelium, and it is the target now of the pathogenesis of the asthma. What happens when alarmins are there, when alarmins are secreted, then the Th2 will be stimulated. It will produce, as I told you, IL-4, IL-5, and IL-13, as well as the innate lymphoid cells producing the same cytokines, and those cytokines will stimulate the eosinophil, as well as the other basophils and mast cells, and the Th2 will end up producing IgE, and that will lead to the airway hyperresponsiveness, remodeling, and hypertrophy. The first topic is the T2 low asthma. What is the overview and management? And this is an important article that you read, all of you need to read. The T2 high, meaning IL-4, IL-5, IL-13, which is eosinophilic inflammation, while T2 low is involving the cytokine IL-8, IL-17. It is the asthma associated with obesity, smoking, no certain biomarkers. This article by Fitzpatrick deconstructed the asthma into T2 high, the early onset, mainly allergic, IgE, mainly eosinophils in the airway, and mainly increased exhaled nitric oxide, normal or too high, usually normal to high. More exacerbations, lung function showing obstruction, the response to short-acting beta agonists, as well as the steroids. The opposite in T2 low asthma, it is the later onset asthma. It's usually non-allergenic with no eosinophilia or mild eosinophilia sometimes, exhaled nitric oxide low, fewer exacerbations, lung function will show less obstruction, and this is the difficult to control asthma, severe asthma sometimes, less short-acting beta agonist responsiveness, and poor response to steroids. The T2 high is the one that we see in children because it's mostly 70 to 80%. With the difference between the childhood asthma and the adulthood asthma is that it is episodic, severe exacerbations, usually triggered by viral or allergen exposure, and the patient will be asymptomatic between episodes. Lung function might be normal, and there will be reversibility. The treatment will be mainly avoidance of the triggers and the immunotherapy, as well as the targeted therapy, anti-IgE, IL-5 or IL-5 receptor, the combined 4 and 13, or the steroids. The T2 low asthma is the more severe asthma with fewer eosinophils, sometimes associated with neutrophilia. Systemic inflammation is here with IL-6 and IL-1, or the postgranular non-inflammatory. What is new in the treatment of this T2 low is the use of the tiotropium as well as macrolides, avoidance of secondhand smoking. And tiotropium is now coming into play, and it is approved by the AAP in the treatment of asthma. The second article of interest is the lung lavage granulocytic pattern and the clinical phenotypes in the children with severe therapy-resistant asthma. This is a big study that involved 22,000 asthmatics from 2009 to 2018. And ended up doing bronchoscopy for 300 children, confirmed asthma between ages 6 and 17 in 126 kids. The bronchoalveolar lavage with those poorly controlled asthma, why is important? You need to know the exact pathogenesis because, as I said, we are now in the era of the targeted or precise medicine. Isolated eosinophilia is in 10%. Neutrophils around 16%, the mixed type neutrophil eosinophils 22%, the majority 52% are the postgranulocytic, meaning no eosinophils. So that means those are the guys that they are not going to respond to steroids or the monoclonal therapy that target those eosinophils. So those ones that you are going to use the biologics. And by the way, even if the biologics are expensive nowadays, I was involved in the early studies during my fellowship training with the Xolair, and we never imagined that the monoclonal omalizumab will be now having studies in age 2 to 3 years of age. So life changes and time changes, and the whole world is a one village. So you should be prepared to know that whether it's going to be expensive or not, we don't know. So those are the biologics that need to be treated, to be used. The isolated neutrophilia, anti-neutrophil therapies, including IL-6, IL-17, and IL-1. Mixed granulocytic, you can use the biologics either or, because you have combination of cellularity, and the post-granulocytic, as I just discussed earlier, that epithelium is the target of asthma. Those type of asthmatics will respond to macrolides and the non-T2 novel biologics, the anti-TSLP, that will be in the market soon. What about COVID-19 and asthma? You've heard this, and the early studies from China showed that asthma and respiratory allergies have not been identified as significant risk. Is it true or not? This study talking about the association of respiratory allergy, asthma, and expression of the SARS-ACE2 receptors. What they did, they had 300 children from urban environment. They did nasal epithelial brushings to detect the transcriptome for ACE2 expression. And the interesting thing is that they found that the ACE receptors was inversely associated with the T2 high biomarkers, meaning the more you have eosinophilic or allergic type, the less ACE2 receptors. And the non-atopic asthma was not associated with the decreased ACE2 receptor. So not all the asthmatics. And look at that. When IL-13 was high, the ACE receptor expression in the nasal epithelium was very low. When in the bronchial epithelium, it was less, but not as, of course, as significant as compared to the nasal epithelium. And you know that the nasal epithelium is the target first for the virus. So you have to know that only asthmatics with atopic background will be less susceptible to the COVID-19 because of the decreased number of the ACE. Not all the asthmatics. And because of the nose colds in children, we've noticed sharp decrease in the asthma-related emergency room visits in the beginning of the pandemic from April down to 85%. Of course, COVID-19, as you know, will change the whole life. The next interesting article in the nutrition is the omega-3 and omega-6 and the ratio, the polyunsaturated fatty acids and prevention of asthma by modification of the maternal diet. We used to talk a lot about it, but this study is really a very red flag for us. We know omega-3 is mainly, generally speaking, present in all fish as well as walnuts. And omega-6 is present in the oils. Are they bad? No, they are not. It's just the ratio. If you have 3 more than 6, it will be anti-inflammatory. If 6 is more than 3, less than 1, then this is pro-inflammatory. So what the study says is the prenatal polyunsaturated fatty acids in the child asthma. What is the effect of modification of the on that in association with the maternal asthma and the child sex? Why this study? It involved 1,000 mother-child pairs, and they measured in the second trimester the N3, the omega-3 and omega-6, and they followed the children outcome to age 6 years of age. Very interesting. They followed for a long time, and this is actually a cohort from, as you all know, the CANDLE study is one of the biggest follow-up study for maternal infant children to see the development of the children as well as asthma, of course. They found that male children born to mothers with history of asthma with higher 6/3 ratio had the highest risk of ever current diagnosed asthma. So if the mother is African American and he is a male child and she is asthmatic, then of course there is a risk of asthma. How about vitamin D? Those are the main two that we kept talking about it. The effect of early and late prenatal vitamin D and maternal asthma status on the offspring asthma or recurrent wheeze. 1,000 eligible ended up having 300 mothers with asthma and close to 500 without asthma. The maternal asthma from data from the VDAART, it's a big, again, study. It's vitamin D antenatal asthma reduction trial. It's a randomized placebo-controlled trial in pregnants with and without asthma. They were given vitamin D in a high dose, 4,000 or 400 daily, and then the levels were measured, vitamin D level was measured early and late, and the primary outcome was seen in the kids later on. And this is the setup. I'm not going to talk about it, but let us look at the results. 26% of the offspring had physician-diagnosed asthma before age 3. Children born to asthmatic mothers were 2 times higher for developing asthma or recurrent wheeze by age 3. And asthmatic mothers whose vitamin D level was sufficient above 30 at early and late, they had 65% reduction in the risk of wheezing in the offspring by age 3. And that protective effect extended to 6. It means polyunsaturated fatty acids and vitamin D to mothers. And look at the results here. This is the probability of asthma, and this is the vitamin D. As we have more vitamin D, the likelihood of asthma decreases from the baseline to the 3rd trimester. What about rhinoviruses? The immune responses, do we know a lot about it? Interesting thing, we have more than 160 types of rhinoviruses. So not every viral infection will be associated with wheezing. Because again, even if it's a rhinovirus, it depends on your immune system or the child immune system, as well as the type of the rhinovirus. In addition to the pollution, and what is more important in this study is the presence of colonization or moraxella, genetic background, of course, and the age of the child. They found that RSV type A and C are more associated with wheezing more than the B if there are more pollution with abnormal immune system and abnormal host genetics. So detailed again, precision medicine, not everything will be the same. Let's look at what are the final stuff that I'm going to talk to you about today is the asthma medication changes in 2021. The updated age for steroids. Budesonide, the Pulmicort, but the Flexihaler, not the Respules. 6 and above, beclomethasone 4 and above, fluticasone propionate, whether HFA or deep powder inhaler. From age 4, the mometazone twistahaler 4, fluticasone furoate from 5 and above, mometazone 5 and above, the combination of the LABA as well as the steroid from 6 and above, but a different steroid, the mometazone, is again from 5 and above. I know that most of those drugs are not available in Egypt, but as I said, since the world is just one village, everything will come to Egypt and it will be there. So you have to be ready. And what is really interesting, and I like it the most, is the FDA added boxed warning to the model UCAST for the potential behavioral and neuropsychiatric disturbances, such as agitation, depression, sleeping problems, and suicidal ideation. I had patients that the mothers told me that children have really a lot of nightmares, and sometimes they hit the roof from hyperactivity. So I'm so happy that this was added. What is really, again, important is the use of the fractional excretion of nitric oxide, the decreased indoor allergens, control. And what is really, again, I like it the most of our patients do not follow our guidelines to stay on the steroids. But now here, the intermittent medication recurrent wheezing is approved. Plus long-acting LAMAs as a step-up therapy, as well as immunotherapy. what is the intermittent medication news? It's not actually the GINA guidelines, but I'm telling you the advice for the wheezing children. Up to 4 years of age, they recommend short period of during the treatment, during the infection episode, between 7 to 10 days, inhale the steroids twice a day, plus short-acting beta agonist as needed. Previously, we used to tell, give steroids and give short-acting beta agonists, oral steroids. They try to decrease the use of oral steroids. Up to 11, single maintenance and reliever therapy, which is the formoterol and ICS. As well as, or mometazone and formoterol. Above 12 years of age, the daily dose, ICS plus short-acting beta agonist, or intermittent inhaled steroids and short-acting beta agonist. For the treatment, the monoclonal therapy, for the moderate or severe asthma, what are the monoclonal therapies that are approved and what age? The eosinophils, let's say bernalizumab is for the receptor for the IL-5, 12. Dupilumab from the name 2, IL-4 and 13 from age 12 and above. But again, anti-eosinophil alone, mepolizumab from age 6, as well as anti-IgE, omalizumab from age 6. Oral steroids, of course, for all ages, and the tiotropium or the LAMAs from 6 years and older. And I think that will add a lot of the drugs to be used for the treatment of asthma and the different strategies. And I wish that everybody will stay safe in this epidemic. Thank you, and you have a great rest of the meeting.